Video where we will be discussing leprosy part 1. So leprosy is also called as Hansen's disease, and it is caused by the bacteria that is Mycobacterium leprae. So the most important cause of leprosy is Mycobacterium leprae, but it can also be caused by another bacteria that is M. Lepromatous. The incubation period is long at 2 to 5 years. Now, this is an obligate intracellular bacteria which has a doubling time of 11 to 13 days. The main virulence factor of the bacteria is the phosphoglycolipid 1, that is PGL1, which is present in the cell wall of the bacteria. Now, this is the bacteria that cannot be cultured in vitro. It needs animal models to be grown. The animal models that we use here are mice, and more specifically, the 9-banded armadillo. So remember, the animal model in leprosy is 9-banded armadillo. Now, this is a droplet infection. It exits via the nose, it enters via the nose, and the primary target of the bacteria are the nerves. Once the bacteria enters the body, it will migrate to the Schwann cells in the nerves which are present in the cooler areas. It will proliferate, it will establish an infection, but that is where the host immune response comes in. And that is what decides the type of infection that we have. Like it is the same with all mycobacteria, where the host immune response decides the clinical features, here also it is the same. In 95% of the patients where the bacteria enters, it will kill the bacteria, no disease will develop. In the remaining, where the immunity is still not decided, it is immature, indeterminate leprosy can develop, which also in 75% of the patients will self-resolve. In the remaining, it goes on to develop manifest leprosy, that is the clinical features of leprosy. There also, if the immunity is good, patient develops tuberculoid leprosy. If the host immunity is poor, they develop lepromatous leprosy. Somewhere in the middle, we have borderline leprosy, BT, BB, and BL. So remember, in leprosy, it is the host immune response towards M. leprae that determines the clinical outcome. So in indeterminate leprosy, the immunity is not mature. It is not decided what it is going to do with the bacteria. This is generally seen in children who are exposed to the infection early in their life. That is, they are residents of endemic areas. Endemic areas for leprosy in India include Bihar, Jharkhand, Chhattisgarh, and Tamil Nadu. This child is going to have a single ill-defined hypopigmented macule on the face. Look at this image here, a single ill-defined hypopigmented macule on the face. This, despite being a lesion of leprosy, will not have any sensory loss. It will not have any scaling. On histopath, the immunity is ill-defined. It does not form granulomas. What you see here is a perineural or a periappendigeal lymphocytic infiltrate. A very important question has been asked in the INI. So remember, perineural, periappendigeal lymphocytic infiltrate. There are no granulomas in indeterminate leprosy. An important DD of this is pityriasis alba, which is a type of endogenous eczema. This is also seen in children on the face as hypopigmented macule. So that is why it is similar. But how do you differentiate? These lesions are multiple. So most importantly, these are multiple. Secondly, they have a fine scaling on the surface, which is also hidden in the name of the disease. Pityriasis on its own means scaling. So these will be multiple hypopigmented macules on the face of a child associated with fine scaling. That's how you differentiate this from indeterminate leprosy. So in determinate leprosy, remember, the disease manifestations can develop along a spectrum depending upon the immune response. If the host immunity is good, they develop TT leprosy. It can vary along the spectrum to the poor immunity, where they develop lepromatous leprosy. But TT and LL are stable forms of the disease. The immune response does not change. clinical features does not change. Patient stays at the same spot throughout the disease. However, in borderline leprosy, it can vary along a spectrum depending upon the immune response. If the immune response improves, they can move from BL to BB to BT. If the immune response worsens, they can move from BT to BB to BL. So this is the spectrum that I am telling you. Now, what is the classification of determinate leprosy? This is called as Ridley-Jopling classification, which is based upon 4 parameters: the immunological, bacteriological, clinical, and the histopathological features. See, it is the immune response that decides the bacteria, which decides the clinical features, and which also decides the histopathological features. So these 4 are interconnected. Remember these 4 points. This has been asked. Now, what happens to the immune response? The cell-mediated immunity is very good in the tuberculoid pole, reduces over the time to LL leprosy, where there is a very poor immune response. A marker of immunity is the Lepramatous test that we do in leprosy, highly positive in the TT pole. It reduces in the borderline to becoming negative in the Lepromatous pole. Now, the bacteria, which can be seen in the slit skin smear, obviously if the immunity is very good, it will kill the bacteria. That will be negative in the TT. As we move to BT, BB, and BL, the bacteria keep increasing while it is maximum 6+ in the Lepromatous pole. Now, what happens to the clinical features? See, if the immunity is good, the bacteria are killed, the lesions will be minimal. So in TT, we are going to have hardly a few lesions with complete sensory loss and hardly a feeder nerve, that is a nerve around the lesion that may be enlarged. As we move to BT, BB, and BL, the number of lesions increase. Coming to LL, these are diffuse lesions involving almost the entire skin. No lesional sensory loss is seen in Lepromatous leprosy, and there are multiple symmetrical nerves that are enlarged all over the body. So see, the clinical features are minimal in TT, and by the time the Lepromatous pole, you have diffuse lesions, diffuse nerves that are enlarged. In the histopathology, this is a chronic granulomatous disease. So granulomas are a marker of good immunity. You get well-defined granulomas in TT leprosy. The ability to form granulomas reduces, they become ill-defined. In the Lepromatous pole, there are no granulomas, there is just a macrophage infiltrate. Okay, so this is the spectrum. Now, coming to the clinical features, tuberculoid leprosy, few lesions, only 1 to 3. When you look at the lesion, you see that this is a well-defined lesion. So a well-defined prototypical leprosy lesion. It is a hypopigmented plaque, and there is a complete sensory loss within the lesion. Also, there are no appendages here because the granulomas that are formed to kill the bacteria, they kill the nerves, they cause sensory loss, they also kill the sweat glands and the hair. So there is no hair within the lesion. There is no sweating within the lesion. This is a dry patch. Okay, so the granulomas that are formed to kill the bacteria, they kill the nerve, they kill the appendages. Now, what about nerve enlargement? You may have a nerve to patch or a feeder nerve, which is enlarged here. So there might be a nerve here which is coming towards this lesion that may be enlarged. Now, coming to borderline tuberculoid leprosy, this is the most common type of leprosy that is seen in India. Here, the immunity is a little less, so number of lesions increase. You see a well-defined lesion In certain areas, it may not be so well defined. Now, there is still sensory loss, which is seen within the lesion. This is also dry. It also does not have hair or appendages. And you see that the infection is trying to spread, form new lesions. So a very important feature that you see here are the presence of satellite lesions. Very important point in PT leprosy, that is the presence of satellite lesions. Nerves can be enlarged around the lesion. So the most important point that you have to remember here is satellite lesions are seen in BT leprosy. As we come to borderline leprosy, this is the most unstable type of disease. Why? Because the immunity does not stay right here. It can either improve, leading to BT leprosy, or it can worsen, leading to BL leprosy. So this is an unstable disease because you hardly find a patient in pure borderline leprosy. This is also the rarest type of the disease. Plus, if you see here, patient will either have lesions of BB and BT, or he'll have lesions of BB and BL. So there are two types of lesions present at the same time in a patient. This is called as dimorphic lesions. This is why it is also known as dimorphic leprosy. So remember, another name for BB leprosy is dimorphic leprosy. The number of lesions here increase. You can have up to 20 lesions on the body which are asymmetrically present. If you look at the lesion, the classic lesion here is an annular lesion. The classic lesion here is an annular lesion which has sensory loss. The nerves are also enlarged. They can be multiple nerves, but these are asymmetrical, means one here, one there, asymmetrical enlargement of the nerves. Now, look at the lesions. I told you these are annular lesions. Annular lesions means ring-shaped lesions. So when you look at the lesion here, this is annular. It is ring-shaped. Every ring-shaped lesion is going to have an inner margin and it is going to have an outer margin. That is what makes it annular. Now, here, if you look at the inner margin, it is well defined margin. And when you look at the outer margin, this is ill-defined sloping margin. So when you look at the lesion from the side, this is how it looks. A sloping outer margin, well-defined inner margin. This gives the appearance of an inverted cup saucer. That is why lesions of BB leprosy are called as inverted cup saucer appearance. Now, because of these multiple annular lesions over the body, it also gives the appearance of a Swiss cheese. So another named finding here is Swiss cheese appearance. Now, coming to borderline Lepromatous leprosy, the bacteria have increased. So you have multiple lesions over the body, multiple nerves have been enlarged. But remember, these are not yet symmetrical. They are tending to symmetry, means they are trying to be symmetrical. They are almost symmetrical, but not completely there. Okay, so what you see on the body here are multiple ill-defined lesions over the body which have sensory loss. So these still have sensory loss with multiple nerve enlargement. So multiple lesions with sensory loss, multiple nerves, that is BL leprosy. Now, in Lepromatous leprosy, the infection has spread over the entire skin. So you have many lesions, many nerves, which are symmetrical. What is the meaning of symmetrical? It means you have same lesions on both sides of the body. In fact, the word that we use here is diffuse involvement of the skin. That means almost the entire skin is involved. And along with the involvement of the skin, there is also systemic involvement. So here the bacteria has spread to different internal organs as well. When you look at the lesions, what do you see? Patient has multiple papules, nodules on the body, and there is a diffuse infiltration of the skin. Infiltration means the skin looks shiny. It is slightly raised, as you can see the patient. Now, an important point to remember in Lepromatous leprosy is, despite the fact that these are multiple papules, multiple nodules on the body, there is no lesional sensory loss in the lesions. Means the sensation in the lesions is normal. That's a very, very important point that you have to remember about Lepromatous leprosy. No lesional sensory loss. The early features of the disease: patient can develop nasal stuffiness and epistaxis. They can also develop edema in the feet, that is pedal edema, due to autonomic neuropathy. Later in the disease, the eyebrows are lost, which is called as madarosis. The bridge of the nose collapses, that is saddle nose. The ears can sag, Buddha ears, and the entire skin becomes thick and rugose. It almost looks like a lion. So this facies is called as leonine facies. That's a very important point that you have to remember about Lepromatous leprosy. And later in the disease, due to diffuse damage to the nerve trunks, patients also develop glove and stocking anesthesia. So leprosy is one of the causes of glove and stocking anesthesia. Remember, there is no lesional sensory loss, but what we see here is glove and stocking anesthesia. Now, there is a variant of Lepromatous leprosy which is called as Lucio leprosy, also called as lepra bonita. Bonita means beautiful. So this is a beautiful type of leprosy because here you do have diffuse involvement of the skin, but it is non-nodular. So there is just a diffuse infiltration of the skin, because of which it looks shiny, all the hair are lost, so the skin is hairless. Patient almost looks like Mona Lisa. This is a beautiful leprosy. Now, there is another variant that is called as histoid Hansen's, seen in patients who had in the older time taken dapsone monotherapy and they developed resistance to dapsone. So they developed this disease that is called as histoid Hansen's. Here there are multiple dome-shaped papules and nodules on a normal looking skin. So one of the causes of dome-shaped papules in dermatology is also histoid Hansen's. Another variant, pure neuritic leprosy. This is a part of the Indian classification. So remember, this is a part of the IAL classification. This is not seen in Ridley-Jopling classification. The term pure neuritic means only nerve involvement. There are no skin lesions. So how does the patient present? Patient presents with sensory or a motor neuropathy in the area of the nerve involvement. And when you examine, you find nerve enlargement. So that's how a patient of pure neuritic leprosy presents. Now, so in the nerve involvement in leprosy, which is the first modality to be affected in terms of function? That is the sensory ability. In them, the first sensation to go is thermal. Most commonly, the nerve involved is the ulnar nerve. Amongst the cranial nerves, we have the facial and the trigeminal nerve. Damage to facial nerve, patient can present with lack of thalamus, while trigeminal nerve, carrying the sensation from the eyes, from the cornea. If there is any dust, any dirt that entering the eye, you are not blinking, there will be a risk of damage to the cornea, and patient can present with keratitis. Now, in the nerve involvement in leprosy, this bacteria prefers these areas that are cooler. So it tends to affect the nerves, cause enlargement in the areas where they are closer to the skin. And most of the times we palpate the nerves and we find them enlarged, but in certain areas where they are very close to the skin, you can also see them visibly enlarged. This kind of image has been asked in the AIMS exam 2019. It has been asked in the FMGE January 25 exam. So when you look at this image in the neck, What is the nerve that is enlarged? Use your knowledge of surface anatomy from leprosy. See, this is the sternocleidomastoid muscle that is going. The nerve that crosses it, it's enlarged. This is the greater auricular nerve. So the nerve that's enlarged is the greater auricular nerve as seen in this image. Now in the eyes, again the leprosy bacteria prefers the cooler areas. So it is going to preferably involve the anterior chamber of the eye. Patient can develop lack of thalamus, which is due to involvement of the facial nerve. In the eyes, a specific lesion that develops due to the bacteria are the iris pearls, which are lepromas seen on the iris. A common cause of blindness in leprosy patients is the development of secondary cataract. Now, there are areas which are preferred by the bacteria, that are the cooler areas. There are also some areas which are spared by the bacteria. These are called as the sanctuary sites in leprosy. The warmer areas of the skin, like the scalp and the axillae. Amongst the systemic involvement, it avoids the lower respiratory tract, CNS, and the female reproductive organs, including ovary and uterus. So these are the systems that are the sanctuary or the spared areas. With this, we finish our module on leprosy part